device perspective, you've heard repeatedly, this wasn't going to be about devices, but everybody's mentioned a device already so far up here. So the world really is very centric to devices. And we like that. That's a good thing for us. We think that's good for all of you out there as well. The device, whether or not it's your smartphone, your tablet, your mobile computing device, or specialty devices. A glucometer can be attached through your smartphone or your tablet, your iPad, whichever, as long as it has a modem and connectivity, and access to a wide area network, not just to Wi-Fi. That's obviously a limited footprint. But there are needs to have specific devices that may have modem connectivity within them themselves. There's a broad range of the type of information that needs to be gathered and shared. Everything from your heart rate, potentially, to gathering, in Anand's case, of what's your blood sugar level, but also video. When you start to think about the ability to be anywhere, let alone in your home, but anywhere in which a doctor or a caretaker can access certain elements and view that there on the spot, and not just in emergencies, but what data can we gather and share, and how do we share that? And that's really where we're focused. Our focus is really around choice of connectivity, so that not only the end user, but anyone in the ecosystem can have a choice of how you connect to get access to data, then how that data is then pushed through the rest of the ecosystem and then viewed again. It may start in a mobile situation, get pushed through, and then viewed again back in a mobile situation, back on the back end. And then the other piece of it is, how does it get paid for? Who pays for it, and what's the choice of paying for things? And I'll just give you one kind of quick example of how we see the industry changing and being more centric to the patient as a consumer and not just as a patient. I think many of you may be aware of the work that Vitality has done with their GlowCap product in the pharma space. And as that product comes to market here this year, there's a number of different ways in which it will be delivered as far as the business model is concerned. One is through the pharma companies and the benefits that they have from a compliance perspective, and how that reduces cost in the entire ecosystem. And so that product may come to the end user at no cost or little cost. The same may be true of an employer, a large employer like an AT&T, providing that service or that product to the end user. And the third category is one that is kind of all of a sudden was an aha for Vitality is, well, shouldn't it be sitting on in the shelves of Walmart? So that if I get it for one prescription that I have, how may I be able to get it for others? And so all of a sudden there's a consumer business model that comes into play with the exact same product, with the exact same usage patterns and needs. And so what we're looking at is, how do you make sure there's enough choice so that all those needs are identified? And that's a big part of what we focus on.
And that's a great segue into the who pays question. So, it's commonly said that mobile health does not have a business model. And I absolutely agree, it has many business models. It's always the right answer, and I think David just gave us 3 of them. So I'm curious if David Inns could actually weigh in on this also. You're not just talking about, hypothetically, mobile health having business models, you're actually currently selling mobile health services to your subscribers. So I was curious if you could tell us a little bit about that experience. What business models do you see working? And not necessarily just the ones you're offering yourself, but others. And maybe how you see that trend evolving, or other new ones coming to market soon.
Yeah, we're really selling mHealth applications at 3 different price points. Currently at $14.99, $9.99, and $4.99, and that's if you don't include free, because we do some that are free and bundling them into rate plans and other things. Obviously, free is a really good price point, and that's the one that we get the most uptake on. But we are seeing solid uptake in the other areas. I think the biggest challenge that we as a group are going to find in direct-to-consumer is really educating and actually, as always in consumer marketing, getting the awareness out there that there is something available that is going to be impactful and helpful for you, and that you can have a 30-day free trial to go and try it and use it and see whether you like it or not. You know, the thing is that if you're really going to do this on a serious level with customer service and somebody who you know that is on, you know, SAS 70 infrastructure and has, you know, privacy and HIPAA and everything else in their infrastructure, it's going to have to be on a recurring revenue model. It's going to be very difficult to have, you know, a $9.99 app and then expect to have some sort of level of customer service to actually service you going forward. So I think that's one of the transitions I'd look and see. I think there's going to have to be a transition of some of these mHealth apps from, you know, downloads to more of an actual service type, and that's the approach we're taking. So those price points I mentioned are all monthly recurring fees, so that you can actually afford to provide a level of service that we think is required for adoption. So you know, the biggest challenge though is going to be that awareness thing, and it's the challenge of all marketers and all consumer marketers is how do we get the word out there to people to really understand and really know that there's options out there for them that are safe, that are easy to use, and that are going to have an impact on their actual wellness.
And one way to drive awareness, I know David Haight, you mentioned employers. That seems to be a central part of for health and the way that you're looking to market, the channels which you're going to market some of the partners you've inked in the past year. I'm curious, you know, how important of a channel are employers, given their centrality in healthcare in the U.S. anyway? Do you think that's really going to be the way that the employer-based business model, is that going to be the way that these services get in the market?
It certainly will be for a pretty broad cross-section of, you know, the U.S. population. There's no question about that. And Anand is really probably better suited to actually address this. But one of the things we are doing with, you know, WellDocs is, you know, some trials with employment companies that have large bases of employees. I think, you know, we're all in a situation of still, you know, seeing what the definition of healthcare reform will actually be, and how much will that impact employers. I will tell you from my perspective, just as an example, you know, personally, the way that the AT&T health plan works is that I pay quite a bit out of pocket first before certain benefits kick in. So the question becomes, you know, which pieces of this, you know, that's covered through my company my company healthcare plan, am I really buying as a consumer certain elements? And some of those might change the way that you know, the end user, the patient consumer, views their ability to take the advice and the direction of the healthcare provider, because all of a sudden it's coming out of pocket, by example. So I think, you know, when we start to understand what healthcare reform really means and what's that impact to large companies, we know that large companies are looking at ways to reduce those costs. And we believe, and Anand, I think you can speak to it probably more specifically, is that there is great benefit to not just the company for what its costs are, but the entire health ecosystem for driving these costs down through some of these programs. So I'll toss it over to you, and, you know, for further comment.
You know, I think you guys are, it's all right, and I think pricing is going to be a cocktail, is the honest answer. And it's going to vary based on a number of parameters. David's absolutely right in addressing the employer aspect. When you think about it, I'll use diabetes as an example. You know, a poorly controlled diabetic costs 5 times what the average patient costs is sustained on a yearly basis. And it doesn't have to be. A good 60 to 70% of that cost can be avoided. And so if you view these mHealth solutions as from the employer channel as a means of reducing the cost, there's actually a huge value proposition. So if you're a Tom Nagel disciple in pricing, you look at this as a value-based pricing that says, I can save this much money. At the same time, when I look at what the actual results, so when you take all the diabetes drugs and you line them up, you know, whether it's orals, insulin, short, long, et cetera, and you look at their A1C reducing potential that they've achieved in their clinical trials. And, you know, there's kind of an average of about, you know, 0.7 of a point A1C reduction, which is huge, of course. A half a point the FDA considers to be, oh, it's wow. So when, you know, when Merck comes out with Januvia and it drops it by 0.8 of a point, it's a blockbuster drug. Well, now you're sitting on a 2-point A1C reduction potential with the trials that we've run.